Great. Well, good morning, everybody. A lot going on. We're doing town halls a little more frequently. I feel like my friend the last few times has always been Kris, so I guess this makes you a permanent friend. Actually, many of the things we've been doing are our projects and so forth that she's responsible for and knows the most about. So you'll be hearing from her today. But I'll just cut to the chase. We sent out a memo about a half hour ago related to our EMR. Bottom line is we're going to be transitioning away from Meditech and we're going to be implementing Epic. And there's some reasons for that. Before I even get into Epic, I have to put a plug in there for how Meditech has served us over the last few years. Actually, when we first started, there would be no way we could have implemented a more robust system like Epic. And we've had Meditech now, I think, 13 years. It was affordable. We were able to use it to make a lot of progress. I know there were some frustrations with it, but I also know what it delivered for us. So all of you put so much time and effort into getting it useful and built it and got good at it and helped us get reports and generate money from it, all those different things. We greatly appreciate that. I do feel like though we've outgrown the system some, and there are a number of reasons, some of which I mentioned in our memo, some of which Kris will go over, but we feel like that probably the two biggest things is Epic is widely used throughout our state, and more we need to share information on patients and amongst providers to make that easier. In two different EMRs, that's a challenge. And the other big reason is so many of our providers, especially the newer ones coming to work with us, they have been on Epic, they've been trained on Epic. This is kind of what they expect. And so it's a challenge to often learn a new EMR and perhaps one that doesn't offer as many of the functionalities that Epic does. For all those different reasons, we felt like it was good to change. It's going to be a lot of work. I don't think it'll be quite as difficult as it was to go from paper to digital. It was such a change for everyone. That said, we're bigger, we have many more services, it's more involved. I'm not diminishing, it's going to be a big lift. It take a lot of work from everyone, and some more than others, but I think we're up to it. I'm excited about it. I hope this time, 18 months, 2 years from now, we're going, all right, we're humming along. This has been a good transition. Of course, like with many of our projects, we will plan well and we'll be organized and we'll hopefully minimize the disruptions. I don't want to get too much more into it. Kris is going to walk you guys through it. We're not assuming that everyone knows what honestly Epic is, or even is that familiar with the EMR or what it does. Some of you are very familiar, but we have a wide audience here and people who work in a lot of different areas. So this will be an overview, much more details to come. And over the next couple of years, you're going to be hearing construction updates, and now you're going to be hearing EMR implementation updates as we move through this pretty exciting time for us. I'm going to turn it over to Kris and have at it. She's going to share a screen with you guys.
All right. Okay, guys. So as Mark has queued up, and as Dan has mentioned, so this is the East Hawaii Electronic Health Record. This is our town hall update for today. So just taking a step back on what is an EHR, I know there's varying levels of use of our EHR within the facility, but basically an electronic health record is a digital version of the patient's paper chart. And over time, our EHR systems have evolved to have some key features. One of them is the patient portal. So that's the ability for our patients to access the chart and their medical records. It's the ability to e-prescribe and send your prescriptions electronically over to a number of different pharmacies. It contains charting and documentation, integration with lab results. Lab results are actually the #1 reason that patients go into their patient portal. And of course, access control. We want to make sure that your records are safe. So that's what an EHR is. And then as Dan mentioned, we currently are on our Meditech vendor EHR. We went live 14 years ago, May 1st, 2010. And we're looking at Epic as a potential future EHR and maybe a little bit more than a potential future EHR. Feel free to chime in anytime you'd like to. All right, but taking a step back to 2010 and taking a step back in time. So this was shots from our Meditech Go Live. Mark is laughing in the room here. Everybody remembers Selena Cuban. She was a fantastic leader. We couldn't have done it without her. Chris Takahashi will likely be taking the charge as co-lead for this go round, and then our fabulous Health Connect team. That is you up there.
I'm 12. Oh my God. Time is fast.
The time has passed. This was probably one of our very first nursing huddles as we went live. And then we do have a picture of Ka'u going live up in the right-hand corner, but time has passed. It was 10 years ago. And just for some fun and some pop culture, what was happening in 2010? Apple unveiled their very first iPad tablet. I think it was too expensive for most of us to even be able to have. We had still 18 million users on BlackBerries. Zuckerman was the person of the year. Facebook was wildly popular with 608 million users. Instagram just launched, so that is 14 years old. Everyone was playing Angry Birds. And of course, Justin Bieber just released the iconic hit Baby. So that was quite a long time ago. And then from a maybe not as fun, but an EHR adoption picture. So where was everyone during this time, and did we implement kind of with the rest of the United States? So on this chart here, just to orient you, we went live on Meditech in 2010, and we did that to try to stay ahead of the curve. And that curve was trying to get ahead of CMS's meaningful use program. And basically what that meant was CMS incentivized different hospitals for using electronic health records and implementing electronic health records. And we meaningfully attested in 2011 and 2012. And then they started penalizing everybody for not being on an EHR in 2014. So that's kind of just a very brief history on how EHRs came to be. They were actually started in the 1970s, but have picked up significant momentum over time. And then that significant momentum also translated to our state. So this is a picture of our EHR distribution and the vendors that each hospital uses directly within our state. And this goes and lends towards a little bit of that interoperability and our ability to share records and share different parts of the chart and information with other healthcare providers in our state. So looking at this chart here, you can see that the most widely used EHR is Epic. Everybody that is circled in red here has Epic. There are a few hospitals on Cerner, and we are the only one currently on Meditech, sitting out here as a neighbor island. This is important for two fronts, as Dan mentioned. One, sharing information if we transfer patients between facilities, and for patients to be able to get their information from one platform. And we'll go over that in just a little bit. But beyond looking just locally, we also wanted to look at Epic nationally and how did they compete there. So this is the EHR vendor share in the US as of 2022. Epic does hold the largest EHR vendor share between all of the other vendors in the United States. They hold 36%. And then when we look at the percentage of beds that Epic also has, so this is beyond just singular hospitals, how many beds does that hospital have? And then how many beds are included in the statistic? Epic holds almost 50% of all of the beds in the US. So most of those hospitals are using Epic. Another a little bit busy slide, but this was just in our fact finding. We wanted to know what are the wins and losses per vendor. And what this means is what parts of the market share is one EHR vendor picking up, and what parts of the market share are other EHR vendors losing. And this is very telling when we took a look at this slide and we looked at the top maybe 3 vendors in the space, which is Epic, Cerner, and Meditech. And in 2022, it was reported that Epic was the only one with a positive market share growth. So that means that the rest of the vendors were actually losing market share. I can take questions on this after. Happy to have one-on-one conversations about this, but these are just some of the statistics. Yes, Hart. Oh, chat. Sorry. Okay. Okay. I think the chat is just saying how great this is. All right. Thank you for that. All right, back to the slide. So if you feel alone in this transition, this slide should bring you a little bit of comfort. So just so you know, we're not going to be alone. Lots of organizations, as shared in the previous slide, are choosing Epic over their current EHR vendor. And this slide just specifically shows the hospitals that are choosing Epic over Meditech. So there's over 625 hospitals that have made this conversion. So this just kind of gives you the warm and fuzzy that we're going to be hopefully in good company when we go and implement this product and transition over. As Dan mentioned, there's a number of reasons why these hospitals are transitioning. And the first and foremost is, medical students and residents, over 90% train on Epic during their residency. The numbers here don't lie. More physicians are using Epic over any other vendor, with 57% of the market share in the ambulatory setting and 38% of the market share in the hospital setting. And then beyond physicians, we also have our patients and our patient users. So MyChart is an application you can download on your iPhone or your tablet, and it's basically a patient portal application. We have one currently today with Meditech, but it only connects really only East Hawaii at this point. I think there's some ability to send out information. I'm not sure how well we're using that, but with MyChart and an Epic's patient portal, you can actually connect all of the patient portals that are using Epic. So if you're going to Queens and you're going to HPH, you can have one application with all your information from both of those entities in one site. And then if we join that, then we could also have HBMC in there. So that's one of another really big factors on patient satisfaction and having patients get access directly to their medical records and their patient care records. Moving a little bit more onto the clinical and organizational side of things. So these are just the top 10 reasons that Epic shared with us on why people move to Epic. One thing that I want to point out here on the slide is an outstanding peer group, which means 22 of the top hospitals in the US are using Epic, and that includes Mayo Clinic, Cleveland Clinic. And we, if we implement, get to actually use some of their information and their best practices in our hospital. So there's this really robust group of information and best practices that Epic helps each hospital deliver. And so we're kind of all providing consistent care between entities. Another notable topic on this slide is an integrated database. It's on one database. And what that looks like, and what that looks like is one unified platform for all of the different products that they provide. So there's no code changes on the back end, and there's just one unified product on the front end. And this would really serve us well for the number of things that we provide here in East Hawaii. Yes, you can get a copy of this PowerPoint. All right, and then maybe the most thoughtful thing that you guys are all thinking at this point is, how will this impact me? So the first line here is, we want to move into a steady state of Meditech support. And what that means is, we don't really want to do a huge, gigantic build of anything in Meditech. We will, of course, fix anything regulatory, anything that is broken and we need to fix and address, we will, but we would pause on anything major that should then be built in a different EHR. We are still completing our business arrangements with Epic, and for some of you, that means that either myself or parts of our team will be reaching out to you and asking you about the applications that you're currently using and how those interface, because we just need to get one complete list of everything that we expect to interact with our new EHR. There will be additional staff for EHR support. This targeted go live here, hold on to the seats of your pants. We're looking for late 2025 if possible. And that will mean a lot of go live support and training in late 2025 to include consultants and staffing. And then changes to the documentation processes. So with Epic, we want to really take advantage of that Epic community that they have and their best practices. We don't really want to rewrite all of our processes again. So we're going to take a lot of their standard content and their evidence-based content that they have in many, many hospitals across the nation. I will leave you with that. If there's any questions, I'm happy to answer them. Or Dan, if you had anything else you'd like to add.
No, go ahead. Thank you for that, Kris. And that was the 5-minute overview for like a couple thousand hours, 100,000 hours worth of work. So,
it was.
But, good intro. And I think it'll be, again, an exciting time for us. A couple of things that I probably just want to mention that I'm sure will end up ask questions. What's this EMR paid for through the Benioff donation. So like I mentioned before in other town halls, Benioff donations were for specific projects, and these projects were not this project. However, we had money set aside for some of the projects that the Benioffs funded, which of course freed up funds and left us in a position, I think, to be able to afford this expense. It is a big expense. Thankfully, it's spread out over a few years. We think we can afford it. We've been fortunate to have had some, I guess I could say some financial success, and our position has improved enough to be able to take this step. So we're excited about it. I did mention in my memo, and I kind of pointed it out, and I think Kris alluded to it, but our providers in some ways perhaps have had the most, I guess, I don't know if complaints is the right word. I've had to deal the most with some of the shortcomings of Meditech, and I know I've heard, the concerns of the last few years, and I'm really happy to get into a position where we can address some of those issues. We can give you tools that you're really excited about to use to care for our patients, and honestly, to make it a better provider experience. So again, excited about Epic. As far as other things, what generally happens when we make these announcements, we get lots of questions the next time we do the town hall. So like last time we talked about a lot of construction, about the Benioff stuff. And then of course, today I probably had about 25 questions related to parking from all our construction and so forth. But before we get into that, give you a little updates on construction and then get into questions. Let's see if we can read here. So Mark, can you make that just a little bit larger?
So Kris Takahashi in her true form has started answering some of our questions for us. Thank you, Kris. The question up here is, Kona Hospital is using QMC's quote unquote version of Epic. Is that what HMPC will be implementing? And the short answer to that is no. We will be implementing our own version of Epic, different from any other facility in the state, and we will be supporting our own version of Epic here locally.
I think one of the things about us is that, we have certainly grown in enough size to be able to, I guess, take the Epic system offering. But even though maybe none of our particular services are huge, we have many of them because that's the nature of living on an island. So we have long-term care, we have outpatient clinics, we have
Oncology,
significant acute care, we got oncology and so forth. And somewhat it's the breadth of it that really kind of drove us to the idea that we needed a system EMR, and that being a bolt-on to someone else's system probably wouldn't be a good choice for us. Let's see, can you address the reasoning behind closing the outpatient physical therapy service? Well, yes, I can talk about that. There was a question about outpatient physical therapy, and I'll do that when I get to questions. Okay. All right, so let's just hit on a couple of construction updates. I mean, nothing major has changed. I will remind and encourage everyone to read the updates on the intranet. They're there, the parking changes, what's coming. Some of the questions we get are like, well, kind of maybe you haven't read updates. So we're trying to certainly communicate and have you have a point of reference. So read those. Some of the specific questions, especially for those on the second, third floors that are dealing with some of the noise right now, how long is that very loud sound that you guys are all having to experience, especially in ICU, and you will also, as they go up on the third floor, as they remove the eyebrows and hang over the windows, there's just no quiet way to do it. You have to cut them off. I got to grind them off, chip them off. But the way the buildings come together, you can't have them there either. So that process should take 2 to 3 weeks. The windows are boarded up. That will come down so we can open the windows, but then they likely will go back up and down depending on how close the construction comes to the windows. We have to make sure people are safe. It is just like I said, it's painful. I was up on the second floor and it's like, wow. But we're doing everything we can to mitigate it, but hopefully just a couple more weeks. I don't want to overpromise, but I think that may be the loudest portion of the project because it's right up on the wall, on the building, right next to the window. And I think hopefully most of the other sounds will be more transient and less loud. Okay. The other projects are moving along pretty much on schedule. Again, we're trying to work and figure out parking. Before I get to the particular questions, valet parking will be starting sometime in May. We're targeting the first week. Some of the issues and the questions that came up about parking for patients and their impacts, hopefully will be addressed through having valet available. I won't get into the details of how that will be structured. I'll probably save that for another town hall. But hopefully we'll get through the growing pains of starting a valet service. I think it will be much appreciated by some of our patients and will help with some of the access issues. Any other things for construction?
No, it's just thank you to everybody. It's so honestly painful to have so much going on, but I think everyone's trying their best to be positive about it.
We have a couple new trailers outside, like a trailer park now, but part of that is in preparation for our work on our family birthing center on the second floor. So the big one will basically be the learning center. It'll just be outside, but it's big space. Hopefully that will help with some of the conference rooms, and we're trying to adjust spacing otherwise. So we'll keep you updated as we go. Well, let's see if we'll see any new questions there. So I'll start in on the questions and we can talk about parking. So parking or access, actually, of course, the first one isn't parking, but the question was a lot of ED patients get stuck in the ED over the weekend, especially Sundays, due to no or very few medical taxis available during the weekend. And so when I looked into this, I believe it's because, well, we do have the ability to get folks to take patients who are discharged or from the ED home during, I guess, 6 days a week. They're harder to find on Sundays. And the question was, could we basically keep our transporters here and have them take people home? And the short answer is probably not right now. I'm sure that that does happen on occasion on Sundays. It would be, I don't think the volume is there, and they also are at risk. Some of our patients live quite a ways out, and most of our transporters do are intra-facility. They'll take patients up to to Hale Ho, Hamakua, or down to Ka'u, or to like Liberty Dialysis or something along those lines. So we'll keep an eye on it, but I don't think we're going to be able to do that, at least not right now. There was a question, is there a possible way to get better lighting for the parking lot? It gets extremely dark, gravel is uneven. So this is deja vu here. I remember when we had the original gravel parking lot before we paved it, it was dark, and it was just kind of yucky. And we paved it and we liked it. So right now we have a new gravel parking lot. People are certainly parking there. Most of the guys that work the 12s, you can, it's dark when you walk out to your car. I don't think that there'll be solutions to light it. However, there are plans here pretty close to when we finish the ICU construction we're actually in the design phase now of paving and lighting that south parking lot, one that's gravel now. It'll probably be a bit bigger, and it will have lighting similar to what we have now. So like I said, I just bear with us. If you're really concerned, you can get security to give you a ride out. Now, I know that when you're ready to leave work, you have to arrange it and you have to wait, and that's not always convenient. But if you got heebie-jeebies and you want someone to, give you a ride out there, it is available. Just need to call security, and they'll give you some transport out there. There was also another question about if we're going to stripe it again, because it's gravel. We put paint on it. It moves around. Yes, there is a work order in, and I believe the guys are going to be getting to that, assuming, of course, that it stopped raining. It's been raining for 3 weeks straight now, but that is planned. An oddball question here: how often are the filters changed for the water refill stations? So like some of the more modern refrigerators and others, when your filter is dirty, you get a blue light, it comes on and tells you change your filter. So if you see a blue light, then you know the filter maybe needs to be changed, and you can decide if you want to fill your bottle or not. but it is on maintenance schedule. They do change the filters. We don't want anybody getting sick. With parking being an ongoing issue due to construction, is there any way that main employee parking lot be monitored better? I see a lot of tourist parking in the parking lot to access Rainbow Falls. Could we put up bigger, better signage? So I think the signage is actually pretty good. The team has done a really nice job, but we tried to make it where almost anyone can see where to park. We may need to, in that lower part of the big parking lot, put something like no tourists allowed here, don't park here, or do something to, to make sure people know it's not general parking for tourist attractions. And we'll pass that on to our security folks too, to keep an eye for that. Honestly, when that happens, we just pretty much encourage people to leave. But that doesn't surprise me though, that, people are doing that. But we'll take a look, see if we can make it work a little better. There was a question about EV charging in the parking lot. Someone said that they park their EV, they plug in at the beginning of the shift, and whether they're 8 or 12, they say they don't have a time to take a break and run out and move the car. And they were ticketed. And could we not be ticketed? I'm kind of paraphrasing it here. Well, we only have like 3 chargers out there, 2, I think 2 or 3.
There's 2 and then a stall waiting to charge.
Right. And so, yeah, you probably can't occupy the thing for 8 to 12 hours. That's not fair to the other folks that drive electric vehicles. So I honestly, if you can't come out on your break at noon or at lunch and unplug it, maybe you should charge it up, just because it's not fair to everyone else who also wants to charge. I know folks hope that we would put in more chargers. I believe when we put in the one in the south parking lot, by code, we actually have to add some more. We unlikely will have a ton of stations around, but hopefully that will alleviate some demand. More and more people are driving electric vehicles. I don't know if we're being ordered. Our organization is a solution for that. So try to share, and hopefully your charge lasts you. Let's see. Couple of questions there. Can we install a light in the upper gravel parking lot? That's up there where the Pink Palace used to be, right?
Yeah, up here.
So I'm looking at you.
Oh, we'll look into it. Yeah, we've been looking at lighting plans across the campus.
I think until you formally pave a parking lot, it's difficult to just drop electricity because there are a lot of safety considerations and whatnot. We may be able to put something on a pole that just puts general light on that area, but doesn't light it like you would when you formally designed it and engineered it. So we'll see if we can do something to make it a bit better there. But
solar option.
Yeah, but then if it rains,
Yeah.
Let's see. Can we do a light? As FYI, audio is very spotty. Is it really spotty? Sorry. All right.
I moved it.
Help. Hey, everybody. No. I think we had it too far away. Kris moved it up. Hopefully it's a bit better. Let's see. Can the parking lot across the VA have the lines repainted when it stops raining? Many employees there don't know how to park within the lines. Okay. I think we can work on that. And I'm wondering if the company/application be adjusted to notify the user, oh, the car is fully charged. We can look into that. I don't know. Yeah, that's a good idea.
I'm sure. Does other companies do that? I'm not sure.
Yeah, but we'll need to look at that. Time limit, regardless of where the car is fully charged or partially charged. We may be able to program that so you get a couple hours and then it stops. So I'm sure that this has come up, and we'll see if we can manage it a little bit better. I'm glad the audio is better. I'll remember next time to move the thing a little closer to me.
And Pona, we'll have some solutions for you guys, maybe not coming on through VDI. So we'll talk about that.
Okay, so on with the regular questions here. There was also a question, let's see. For the safety, can install more lights. I think I already answered this one. The other one was clinic nurse managers and clerical supervisors have admin parking privileges. Is there any plan to include nurse managers as well? So I checked into this. Only clinic administrators, not managers, have blue stickers according to their boss, and the clinic managers and clinical and clerical supervisors do not. So I think we're trying to be consistent. Ideally, everybody could have specialized parking, but right now they don't. But hopefully, we're being consistent, so not to exclude anyone that should have, I guess, preferred parking. A common complaint for patients and staff is that the parking stalls are becoming further and further away from the facility, and patients and staff continue to recommend parking garage. Okay, so there is truth to that, especially during construction. So when the new expansion is completed, and remember the whole thing, the whole first floor is under facility parking. So what now is completely gone, patients will have the parking closest to the building underneath the expansion. So above would be the ICU and above that the PCU, but that floor will open up a lot of parking right next to the building for our patients. They're our first priority, right? And so everyone gets to, we get that back, which should shift people in to a point. Also, the medical office building 3 will be done, and a lot of that parking that's gone away, you should get some of that back. And this addresses another question that comes up about the question of the parking across the street. So where the, I don't know if it's the greenhouse anymore, that little house where people used to smoke, right?
It used to be green.
It used to be green. We bought that land, we own it now, and we're designing where that whole area becomes parking, and it improves the flow. And it also has undercover drop off for patients. And by the time we're all done, we're hopeful that our patients will have really good access to the building. A parking garage, honestly, we probably never will build because land for us is, well, we have land. We have a lot more land across the street. A parking garage is very expensive, especially here on a neighbor island. And generally, you only build them when you're in like in an urban area where you literally have a little postage stamp and you got to go up, or there's just nowhere to park. So I think we're all going to have to get our steps in, but for our patients after construction, they should get in closer to the building. Okay. But I have a feeling that's not the last time I'm going to get asked that. Can we have our students park farthest away in the farthest parking lot? Yes, they are supposed to do that. They are directed to do that. They've been directed to do that for years. Sometimes they kind of forget, and we have to remind them to work with their instructors. We have a lot of students that come here, but yes, we will refresh people on that. This is maybe people get a little, it's the end of the semester, maybe they get a little forgetful.
Right, it's right before summer.
Yeah, we'll work that. It's almost summertime. We'll have to work on that. I mentioned that about 1285, about the need for a drop-off area. We agree, more handicap parking, we agree. One of the things that you may have noticed that we're doing is that parking lot right in the front of the original office building where the Radonk is and now urgent care is. We have a security attendant there, and it's just for mobility impaired. So they have first choice, and we also have the security guard there to make sure that people can drop off and that the parking lot stays organized. So that will help some. Ultimately, it'll be better when we pick up and fully pave and engineer that lot right next to it. So again, a lot of growing pains here. Keep your comments coming. We know that it's not perfect right now, but hopefully we can get through the next couple of years. Do a good job there. There was a question about the expansion of the facility and with the CSR department. So that's basically procurement and material management, get more staff when the place increases. So generally for almost any of our services, as the work increases, we try to keep up with staff. Now, we generally make sure the work is there before we add the staff, so sometimes there's a lag, and I hear about that too. Just because you add more space doesn't necessarily mean, though, that you have to we're having more business, but I think there will be some of that as we already are full and as we move some of our patients up, we probably will get some new volume and we'll try to make sure that our material management folks and so forth are staffed. Joni's quite the advocate for that, and I'm sure that she will let me know that when it's time. But thanks for asking the question. Let's see. Is it possible for us to purchase at least 3 to 4 6-passenger golf courts to take patients back and forth to their cars after being discharged from the emergency department? So we did get a 6-cart new golf cart, and we have seen some folks driving it around, but we're getting a little more organized here where we're going to have people only driving that cart around to haul patients back and forth. Okay, so that hopefully will be available. The other thing with valet parking being available, we hope that that will also help with some of these particular issues. We start with the 1 golf cart and the security person to shuttle people, and we'll see how that goes. And if we need to add more, we can. And will we be adding walk-through metal detectors to the facility other than the ED? That's not in our plans. I'm pretty fixed on the idea that our hospital is a community hospital and there's always some risk, but general consensus in the industry is to have metal detectors in your emergency room. I don't want to lock down our hospital. We have security present, we have screeners, but no, we won't be screening everyone who generally moves in and outside of the facility, at least not at this time, and hopefully we'll never have to. So knock on wood there. There was some question about getting healthier hotline options in the cafeteria, specifically less fried and more vegetable-based options. Even someone said, could we have cubed sweet potatoes instead of mashed potatoes? So I looked into this, and basically the feedback is when we offer healthier options, nobody buys, so sorry. Like our fried food and our other stuff, but really the sales are quite low, and what happens is you end up wasting food, or we have to, make a certain volume for it to be effective. So I think we'll continue the vegetarian option. I don't think, honestly, that we'll be kind of shifting to maybe a too much more of a healthy menu. I like to tell you we would, but maybe I don't know, maybe we all need to eat better.
They are trying. They're trying very hard to bring in better products that are healthier for you.
But people gotta want to eat them.
Yeah, people love the fries and the fried food.
I know.
And the loco mocos.
Yes. The salad bar, we used to have an open one, but we have a big grab and go freezer, not freezer, but refrigerator. And so you should get a big selection of different types of salads. So honestly, there's a lot more healthy options in the grab and goes than there probably are on the tray line. So hopefully that will help. And by the way, we are working on getting night shift food options. I can't give you a date, but we're working on it. We know that that's a big deal for folks. Let's see. Is there help for transporting patients have a hard time walking from parking lot to entrance? Those are elderly and so forth. I don't know if you've been out to the handicap parking that's past the expansion, but we have a tent out there, we have wheelchairs, and we have a screener that sits there to roll patients who park in those handicap stalls all the way into the hospital, unless their loved ones need help doing that. So we do have someone out there. Hopefully that will help with that particular issue.
There's also a line you can call. So we're passing out cards and there's a phone number published. So if you pull up in any stall and you need help to get into the hospital, you can call that line and somebody will come out to get you.
I think there are numbers, big signs in the parking lot across the street, right? Okay. Someone said at the last town hall, I said that we wouldn't be rebranding everything. Now there's talk of new badges for everybody, repainting signs, replacing doormats, new shirts, and all kinds of other stuff related to rebranding. What changed? So I know that I said we would rebrand. You can look at, go back and watch it on YouTube if you want. What I explained is it would take about 6 months to do because there are many different pieces, right? So all the things that you mentioned, we actually will change over time. However, like we're not going to collect all of Mark's jackets, shirts that have Hilo Medical Center on the logo. But as a matter of fact, even the hospital week gifts that we ordered early will all still say Hilo Medical Center, because we weren't going to just, throw them away and just change. So some things we will continue to use and they will kind of go away over time. But other things like your badge, if we didn't change badges, I know people held on their badge for 10 years. So we will absolutely rebadge everyone. Those are very visible indications of the name of the facility. Certainly the big signage, those sorts of things will also have to be changed. But I've got a team working on this, and we want to get most things done by July, and we want to get everything that we can within reason done in September. So that's 6 months. So I'm glad you asked the question, but yes, we will rebrand, but it won't be an automatic, and we're not going to go collect all the old stuff. Okay. Did the admin parking blue parking sticker near the new gravel lot, I think that's below Bob Medical Office Building 2, turn into regular employee parking green sticker? It stayed admin parking for now. Okay. We probably will use that space further on in the project temporarily for to put steel down as a lay down while we put the structure of the building up, but then we'll put it back. For now, it's still admin parking, so it's still blue sticker. I know this question is probably the 5th time this has come up, and I understand why. There was a question regarding patient privacy in the lobby. It's because when you have someone who's maybe a little hard of hearing, they'll come up to the window. There's a cutout and a speaker. And people, if they're hard of hearing, they tend to speak very loud. And so you ask someone a question and they're given their private information where half the lobby can hear. And we understand that. We have a phone. There is the ability to bring people in, but I know that they really don't necessarily want to do that. So the question is, what are we going to do about it? Realistically, except for what we've done, I don't think there's a lot we can do about it without majorly redoing the lobby, and we're not going to do that either. So I think those situations really need to be handled individually with the patients who are perhaps very loud. If we need to, the patient service representative can come around to the outside and talk with the patient there, or bring them in if you need to. I understand that's not convenient, but that likely would be the realistic solution that we have right now. And I figured we've looked into other options, and I give you the answer straight up. I don't think we're going to be changing any of the infrastructure in the lobby.
And Epic has kiosks, so that might be a helpful recommendation.
There was one, I only have 2 more, so those of you bearing with us here. There was a question about when patients get charged from the emergency room, staff take the patients in wheelchairs to the parking across the street at all hours of the night to pick up or drop off patients. Security was asked and told they can't take patients due to liability. There's no wheelchair ramp, so staff has to walk on the road, go down the main road to get to the parking lot. And especially at night, this is not safe. We were told we should not be taking patients to the car related to our safety, but in these cases we do. Is there a solution? How can we fix this? This one's a little tricky. I know that, and I'm assuming that the patient doesn't have a family member, because ideally the family member would go get the car and bring it up and load up the patient. If the patient has to be wheelchaired to their car, but then they're driving their car, it's kind of like, I'm not sure if they're safe enough to drive their car home. Could they walk? But maybe you don't want to do that because it's dark. Those solutions are a little tricky. I understand that, we don't have a crosswalk or a way to get across the road. Hopefully this will be alleviated some when we have the expansion done and we have that patient parking right next to the building back, where you will have to take people across the street less. I think that's just unfortunately going to have to be handled on a case-by-case basis. And then the last one here, question about differential for ICU. Some of you are aware that like some of our other facilities, we pay different rates for for folks who work in different areas. Like in Honokaa, we have some of our facilities. There's a facility differential. In our ICU, we pay a differential for critical care, for ICU critical care. I guess I give the same response that I've given before. We welcome people who want to work in ICU. Still, even now, we are training just about everyone that works in ICU, which is very expensive. If you have critical care experience and you want to work in ICU, I think you would be welcome. Right now, we pretty much take people from new grad to critical care and invest literally thousands of dollars to get them there. And I think at last count, we still had 9 travelers in our ICU. So the differential is there because the market demands it. As much as I love all you guys, as a business, we only pay what we need to pay because we need to be good stewards of our money, and we need to use our funds as much as can for our patients. So we pay it because we have to, and it's actually pretty standard in the industry right now. So I appreciate the question. I understand why it annoys some folks, but you asked, so I give you a straight up answer. So that, a lot of questions, a lot of parking issues. Hopefully we'll get better at managing the parking. Future questions coming. I'm sure next time we'll have questions probably about ethic and other stuff. Then I have a last one here about physical therapy. So we do we have offered outpatient physical therapy. We do it in Honokaa, and we also have done some of it here. We're going to be more consolidating what we're offering for physical therapy, shifting some to Honokaa and some into our clinics. The reason for that is we are doing quite a bit of shuffling in the hospital for space. We have a long-term plan. It actually should say long-term, a couple of year plan to shift our laboratory location to the rehab and gym area in the basement. And so we can then expand some of our imaging and the space right now where we have MRI, CT. That is a big growth area for us, and we're a little confined. So that requires a shuffle services and sometimes a consolidation of them. I also know that we have a lot of physical therapy in the community. It's one of the areas where we are blessed to have services. So we're trying to be a little, I guess, I won't say wiser is the right word, just a little more strategic about what services we offer, how we support our orthopedics, and also what we have up in our critical access hospitals. If you have any more questions about that, I'm sure your managers, administrators can share some more with you. I think we've covered everything. Oh, where would the valet cars be parked? You want to do that one?
Sure. So right now, because they're just patient cars and they're visitor cars, we are carving out an area in the visitor parking lot to put those cars.
And also, I mentioned it about night shift food, but has there been progress on food being available for folks on night shift?
We are still looking at some vending options, so we can fill those vending machines and there can be options there.
So when? She hates this.
I do. You just put me on.
So when?
This was not on my stuff to answer. I would say give us 90 days. Joseph is on, he can chime in on the chat, but.
I know that they've been working on it because when I see Joseph and they've talked there, it's not as simple. You got to meet food safety requirements. You got to be able to make it. You got to make sure what you offer people like. It's like many things. It sounds like, oh, sure. But when you look through it, it's not impossible, but it takes a lot of prep to do it right. But I know they're working on it. And I was just kind of teasing. I wouldn't be surprised if maybe 90 to 120 days. Give yourself.
Right. If we could find the vending machine, which I think that's what we're looking for, to maintain temperatures up for the food.
Okay. Instead of just naming, someone says that they liked the article in the paper stating why do we need to change the hospital name, and Justin said name a name after the Benioffs, and that could have been an option. Honestly, the donor wanted to name the hospital, not the wing. And so we did have a discussion about that, and we felt, or really I felt that way, as well as our board, that that was an acceptable thing to do, to name the hospital as we did. So it's a reasonable question, and it was discussed. And everyone, I understand your opinion. I know that some people share it. Let's see, did we
Joseph,
get everything?
yeah, Joseph said, we are working on finding a great solution for the vending.
All right, positive question. All right, I think we went through pretty much everything, and so hope you guys have a great day. A lot of work to do. Thanks for everything you do, and you are appreciated. Aloha.